Hello, my name is Christelle Haziza. I'm a doctor in biology and director of clinical science on biostatistical group at Philip Morris. And today I'm very happy to present you the approach that our company has taken to evaluate tobacco harm reduction when switching to tobacco heating system. Multiple diseases are attributable to smoking. Among the diseases, the main ones are lung cancer, chronic obstructive pulmonary disease, and ischemic heart disease. For smokers, it is without question that the best way to maximize reduction of risk is to stop smoking and this continuously. But we cannot ignore that still 1 billion of smokers exist worldwide, and we need to address their risk. One of the approaches which could be complementary is tobacco harm reduction. But what is tobacco harm reduction? Tobacco harm reduction has been defined as minimizing harms and decreasing total mortality and morbidity, and this without completely eliminating tobacco and nicotine use. The question still remains that how do we provide earlier evidence than epidemiological data? And how do we evaluate reduced risk in that context? Unfortunately, currently, there is no consensus within the scientific community or the regulatory bodies. To address that question, we have designed three clinical studies that are presented in this slide. The exposure response study enrolled approximately 1,000 subjects, healthy smokers not willing to quit, in a randomized study with two arms. They were asked either to continue smoking their own cigarette or to switch to THS for a 6-month period. This study was extended by another study of 6 months duration. The first study was a confirmatory one, when the second one, the extension, was a descriptive one. This study was conducted in US across 20 sites. In parallel, and to understand the relevance of the result when switching to THS, we have conducted a smoking cessation study across 42 sites in US, Japan, and Europe. This study enrolled also approximately 1,000 subjects, healthy smokers willing to quit. These smokers were asked to continuously abstain from smoking for a period of 12 months. In these studies, the same endpoints were measured at similar time points. Now, how did we decide to evaluate tobacco harm reduction? We use biomarker of potential harm, and I will explain why. Biomarker of potential harm are measurement of an effect due to exposure. These include biological effect, alteration in morphology, structure, or function, and clinical symptoms consistent with harm, and also include preclinical changes. Of course, we cannot select biomarker of potential harm at random, and to provide with a fine selection, we define them a priori following the Hill's criteria, taking into consideration their involvement in the pathways, their association with long-term morbidity and mortality data, but also their dose relationship with smoking status, and importantly in that context, their ability to be reversible upon smoking cessation. By using this approach, we ended up with 8 biomarkers of potential harm altogether that were covering 8 different pathways, which are listed in the slide. All these pathways were reported by the Surgeon Report Smoking Cessation to be well known to be involved in the development of cardiovascular, COPD, and lung cancer disease. To be able to show modification of risk profile with THS, the assumption was that all these biomarkers of potential harm should move in the same direction as smoking cessation. Let's have a look now at the result of these studies. The slide describes on the left panel the result of a 6-month study for product use pattern on nicotine exposure and reduction in exposure to toxicants. On the right side, we presented the result of a 12-month study. The result showed that Among people who were randomized to THS, approximately 60% of those were predominantly using THS, meaning using it more than 70% of the time, still allowing up to a maximum of 30% of cigarette use on a daily basis. The results showed that these people, classified as per self-reporting, were using on average still 2 cigarettes a day. 34% of people were dual using both THS and cigarettes. And in this category, these people were smoking 10 cigarettes a day. When looking at the reduction of exposure, reduction was observed in predominant users of THS and also in THS dual user. However, in dual user, the reduction was much lower than in predominant users. When moving to the result of a one-year study, all the results were maintained. We have not seen any change in product use pattern, neither in the reduction in exposure. Importantly, over the one-year period, there were no change from baseline in nicotine exposure and overall daily consumption of both THS and cigarettes as compared to baseline. Here we presented on the graph the changes between predominant users and smokers for the 8 biomarkers of potential harm that we have presented before. It is very striking to see that switching from cigarette to THS modified the trajectory profile of all these biomarkers of potential harm as compared to smoking, in the same direction as we observed in our smoking cessation and as reported in the smoking cessation literature. At 6 months, 5 out of the 8 were statistically significant between THS and cigarette smokers. Looking at the data of the 12-month study, these favorable impacts were maintained over 1 year of use. Because subjects were classified according to product use pattern based only on subject self-reporting, and because we know self-reporting has a limited accuracy, especially over a 1 year period, we decided to stratify the predominant user according to quartile of SEMA concentration. SEMA is a biomarker of exposure to acrylonitrile. The assumption behind was the lower is the exposure to SEMA, the higher will be the beneficial impact on the biomarker of potential harm. We presented here this stratification for the 8 biomarkers according to quartiles of SEMA. We had 3 quartiles, and according to the time point of study measurement, 3 months, 6, and 12 months. Very clearly, you see a dose response to the intensity of exposure, and we verified that the lower is the exposure, the higher is the beneficial impact. In other words, the less THS user smoke cigarette, the higher the beneficial impact will be. All the results I have presented you before were about the difference between switching to THS compared to cigarette smoking. But to understand the clinical relevance of a modification of trajectory profile in biomarkers, we wanted to compare the magnitude of effect observed with THS switching to the magnitude of effect observed when quitting smoking. To do so, we matched the population which was enrolled in the exposure response study to the population enrolled in the smoking cessation study by propensity score analysis. The graph showed you very clearly that for 4 biomarkers of potential harm, the effect of smoking cessation was preserved by up to 50% when switching to THS. This was the analysis done based only on self-reporting from the subject. In this population of predominant user, we use a cutoff of SEMA of 14 nanogram per milligram per creatinine to detect cigarette smoking. For those smokers who were below 14 nanogram per milligram per creatinine, the preserved effect of smoking reached up to 67% in 7 out of the biomarker of potential harm. It is important to notice that for all of the endpoints assessed, The switching to THS modified the profile as observed when stopping smoking, except of course for nicotine exposure and overall tobacco use, which was comparable to baseline value. And this was expected. As key takes away, complete switching from cigarette to THS preserved the effect of smoking cessation by at least 67% over 12 months of use in 7 out of the 8 biomarkers. What does it mean, these results? I remind you that these biomarkers were linked to long-term morbidity and mortality and were involved in pathways underlying development of disease. So these data provide evidence on the potential of THS to reduce risk long-term in terms of morbidity and mortality associated to the main smoking-related disease. Profile of changes in biomarker of potential harm after switching provide relevant insight for evaluating tobacco harm reduction associated with alternative products when evaluated in light of smoking cessation in absence of epidemiological data. Thank you so much for your attention.